and welcome to the EMS Handoff Podcast, your source for all things EMS. With me tonight is our colleague, our friend, Bradley Dean, and we have our guest, Jason Haag, and we are missing someone. We are missing our fearless leader, David Blevins. He is out, but he will be back with us next week. Until then, we can heckle him from the distance. I think maybe he was just enjoying this. I don't know. I'm not a football fan. I'm not a sports fan or anything like that. But is this the first weekend of football and stuff? Maybe he was having a good time doing that.
I'm not really sure. I got my heart broken today, so it's okay.
Oh, okay. So, all right. See, so maybe no, he's not. He's actually just under the weather, so he wasn't able to join us tonight. But that's all right. We got you two, so we'll have a good time tonight. Before we get started, I just want to make sure that you guys reach out to our sponsors at Pursue Outfitters. We have some really good gear there. I have the t-shirts, one of the ones that I wear it all the time. I work out in it and stuff. The EMS Handoff one, the 50 feet back one, that's a really popular one.
This one right here, this t-shirt. Yep, right here. There we go.
Yeah, that's the one. Yeah, I have the black one. The reason why I'm not in it right now is because I've literally been out in it running and doing all that stuff because I was working out tonight. So that's why my camera isn't on. And it's pretty awesome. I like the 50-foot back one too. That was a good one. So yeah, and I appreciate you wearing that, Jason. And he's got our background, so that's cool. He is representing our podcast. I enjoy that. Also, make sure to check out our podcast at JEMS, Journal of Emergency Medical Service. While we provide content and resources for all things EMS, they do the exact same using other vendors and other people, other podcasts and other resources. So make sure to check them out, as well as their other line of podcast players and podcasters as well. I wonder if they do the same thing for us. I want to say, hey, check out those awesome guys on EMS Handoff. We also have a Facebook group. So join the Facebook group. We'll get on there. We'll chat. I'm trying to get more plugged in on there when we ask questions and things like that. And we try to integrate that with people's questions and answers into these podcasts. I forgot to do that today. I'll do that next week. Yeah, probably next week. I'll do that next week. It's looking good for next week. So before we get too far into this, though, and we just delve into what I have been calling everything else under the sun other than delayed sequence intubation, let's first check in with our colleague and our co-host, Bradley. How's things going, Bradley?
Man, things are going great. A little busy tonight, so I'm actually joining you from my vehicle as we're doing this. So thanks for everybody joining us, and I hope you enjoy the conversation and topic tonight. So.
Yeah, and in fact, speaking of the conversation and the topic, let's go right on into it. What are we going to be discussing tonight?
So I think we're going to talk a little bit about delayed sequence intubation, which I think a lot of people look at it and they think, well, RSI. Well, there's nothing rapid about it, and we probably did a bad job of calling it that to begin with. But we should have really been looking at what can we do to maintain a patient's airway, what can we do to appropriately prepare the patient. So I think it's important that we look at the three main reasons patients should be intubated, and one of those is failure to maintain their own airway. Two is inability to oxygenate or ventilate, and then the last one, of course, is anticipated clinical course, which is most of the time what we're dealing with. It's usually not something that has to be done right away if we're going to use pharmacology to do that. So thankfully, we've got Jason with us tonight, and he's got a varied background with that. So, Jason, turn it over to you.
All right, thanks, Bradley. So delayed sequence intubation. Some people who are not familiar with pharmacology assisted intubation, if you will, or medication facilitated intubation, a lot of folks are not entirely sure what the difference between RSI and DSI is. RSI, as Bradley alluded to, is rapid sequence induction. And the only thing rapid about doing that is the speed at which you push those medications, that induction agent and that paralytic. The rest of it is time consuming. It's arduous. It's you taking the time to prepare your equipment, taking the time to determine if your patient's airway is going to be a difficult airway or an easy airway. Getting all your tools ready, your primary airway, your secondary airway, your tertiary airway, should things should things not go well for you. Being prepared for a surgical airway should you find yourself in a crash airway situation. So that's RSI. DSI is a totally different mindset. Delayed sequence intubation or delayed sequence induction. And I can't really use induction in that because we're technically only doing induction with DSI. DSI is pumping the brakes on this whole concept, right? Maybe we don't necessarily need to put the advanced airway into our patient. You know, I'm sure, and obviously with this being a podcast, this is a rhetorical question, but I'll ask this to Eric and Bradley. How many times have you guys interacted with a patient who is hypoxic because of them being combative secondary to some kind of a mental health or psychiatric issue, or maybe head trauma or hypoxia? They're combative. They're not letting you get that non-rebreather mask on them to pre-oxygenate. You guys have met those patients, right?
Oh yeah, absolutely. And yeah, and speaking of which, I want to qualify my lack of expertise on this subject. Where I came from, we didn't have RSI protocol. We had assisted intubation intervention, something I can't remember the exact terms it was. But due to my lack of experience in facilitating intubation via medications and stuff, I was always very hesitant and nervous about doing that with somebody. So I came across many patients who would have benefit greatly from this intervention, but based on my lack of training and experience with that, and I really do think like, okay, so if anybody's listening to this and be like, well, dude, you should have just, gussied up and just done it. Like, yeah, I could have, and I could have also killed a lot of patients along the way. So without proper training and proper guidance in these techniques and stuff, I was always hesitant when I came across these patients. And I've came across them like TBIs, like you said, hypoglycemic or even hyperglycemic patients, psychotic patients who needed some form of airway control. And it was kind of out of my hands. It was more of modulate my treatment pathway based on how they were with me. And I mean, I still got the job done. We still got the patient where they needed to go, but it was always a point of contention for me as to whether we could do it. Like I said, we were never cleared for doing RSI or some form of DSI.
Right. So, so DSI wasn't a big thing in our region initially, and then we took over the control of RSI regionally and credentialed a handful of providers to do it with extra training. And when we got that under control and got to a point through quality assurance with RSI, where every single RSI was done in the field was done successfully and it was needed, then we moved into implementing DSI as an option for those providers as well. So, so you can't do this without an arduous quality assurance and arduous training program. It doesn't work. Bradley, I think you were going to jump in and say something, so I'll turn it over to you.
One of the things I was going to say is you were talking about hypoxic patients. One of the things that people need to understand is sometimes all it takes is a little bit of sedation. You can oxygenate the patient, bring them up a little bit prior to pushing a paralytic or anything else. And sometimes you may not even need a paralytic if you're
Exactly.
using ketamine or something else. And because if you push a paralytic, so there seems to be a correlation when you look at some of the research. When you push a paralytic in a hypoxic patient below 90%, they are like, I want to say a similar in the neighborhood of like 19 times more likely to go into cardiac arrest. And there's a correlation there. Don't quote me on that 19 times. I'd have to pull the research. I don't have it right in front of me, but I have read quite a bit of that lately. So if you're a provider and you have a hypoxic patient, be very, very cautious in pushing a paralytic before oxygenating those patients, unless you're in a crash airway algorithm, but that's a whole different discussion.
Right. And really the name of the game with this is to avoid that crash airway algorithm, is to totally avoid even getting into that situation, right? If you can control it at all. So there's three things really to kind of that I want to hit on tonight is DSI as a whole. I want to talk about ketamine too as a sedative or induction agent, if you will, of choice, and jump down the ketamine rabbit hole for a little bit and talk about its lack of cardiovascular collapse. All right, talk about why ketamine is so safe for that, and then just a couple other tips, right? So as we're looking at this approach to DSI, let's consider three different patients, right? You have your agitated patient for whatever reason, head trauma, psychosis, drugs, whatever reason. So you've got your agitated patient with normal lungs. Your second patient is your agitated patients with lungs that are capable of pre-oxygenation with a non-rebreather. I'm pretty happy with that patient, right? And then you have your agitated patient that's going to need CPAP to pre-oxygenate. And remember, we're talking about pre-oxygenation as we would if we were approaching this as we were going to RSI this patient. So the biggest concern when we're going to do this, especially with pre-oxygenation, is this battle of the non-rebreather versus CPAP, right? And it's difficult to select these patients. Who's going to benefit from which one? All right, you kind of got to have some knowledge with this, and overall, the school of thought that I want people to be in with this after this podcast tonight, and diving into some more information, some more training, because the last thing I want anybody to do is go out there and actually do DSI in the field, because Jason on the EMS Handoff podcast talked about it for 10 seconds, and now I'm an expert in DSI. Please, this does not supersede your local protocol or training programs or anything like that. So not that my colleagues, Bradley, Eric, and I aren't smart folks, but we don't supersede your local protocol. So please don't take this as well, these guys on the EMS podcast said this was cool, so I did it.
Yeah, and that's another good.
Way.
Yeah, and that's a good point. Like, anytime you see, I don't care if it's a YouTube video or whatever, you need to have a well-rounded foundation, because otherwise it's all ego. If you're just doing something because you read that you could do it, or you've seen some studies and stuff, without having your skill sets validated or certified in some way, or going through some process of quality assessment or validation, you really shouldn't be performing these skills, or at least not performing them without a licensed supervisor who can oversee your role. And I've noticed this as practicing under a physician in pediatric urgent care settings. It's been really helpful to have a pediatrician standing over me while I do like different skill sets. So I'm not just rogue doing this on my own, because like you said, oh, I saw it on the YouTube video, now let's go try it out. So that's always a good point, not just for this podcast, but for really anything you read or hear.
And for our legal friends out there, regardless of what we talk about, always follow local protocols, policies, and procedures.
Yes, exactly. So, so realistically, the outcome that we're going to drive towards here is the fact that these patients may actually not require intubation. They may not require it at all. What they may actually require is our expertise, if you will, simply maintaining their sedation and some non-invasive airway management, some non-invasive positive pressure ventilation, if you will. So what's DSI? You know, we want to dive into what DSI is a little bit. It's really just two parts. It's procedural sedation with whatever pharmacologic agent you choose to stay with, and oxygenation, non-rebreather, CPAP. CPAP's usually going to be your modality of choice. All right. So what's your procedural sedation? Right. If you look at an actual definition of procedural sedation, it's a little bit something similar to dissociative medication administration solely for the purpose of allowing pre-oxygenation. That's kind of what we're looking at as an actual definition here. And who might this be ideal for? We've talked about this a little bit, but let's jump in a little bit deeper. And this could be really ideal for a patient who won't tolerate an oxygenation mask for some reason, not a rebreather mask, let alone CPAP, and their oxygen saturations are not optimal for going towards that rapid sequence intubation for that RSI. You know, as Bradley said, you know, you get these folks that are hypoxic, and then you try to pre-oxygenate them, and for whatever reason, you're not necessarily the best with your success, and then you paralyze them. You're opening yourself up to have a really, really bad day. So if we could avoid that, this is what this is for. All right. So normally the concept is to give these folks some ketamine, and typically it's a little bit lower dose. Typically your dosage is going to be 1 milligram per kilogram. That's pretty easy math. I like easy math. So whatever their weight is, that's how much ketamine they get. All right. And the awesome part about ketamine, if you're not familiar with ketamine as a pharmacologic agent, my area has been fortunate enough that we've had it for a while. We were the first region in New York State to carry it in ground ambulances. And ketamine's phenomenal because it allows us as humans, when we get ketamine, to maintain our airway reflexes and to maintain our respiratory drive. We use a lot of benzos for sedation, but the problem with that is it decreases our respiratory drive a little bit and it brings down our ability to manage our own airway. We give somebody ketamine, lower dose ketamine, 1 mg per kilogram, patients are able to maintain their own airway. They're able to breathe at their normal ventilatory rate. It works great. And with that, it allows us to have the patient sedated a little bit to maintain their own airway and to provide them that extra little bit of pre-oxygenation help. All right. So we can do that, and then we can wait 2 to 3 minutes, and then we can make a decision. Do we need to push a paralytic and take over their airway, or can we just hold off?
And I would imagine that at that point, you know, especially with you and pretty much inducing the parasympathetic system with ketamine, because I mean, things are going to start to calm down a bit. You won't have as much vasoconstriction because hopefully you'll have somebody who is not as clamped down as they were. So I would imagine you're going to have a little bit of an improvement. I mean, this is the whole, we're doing no further harm.
Right.
By doing something like this, and you know, taking that OODA loop into factor where you're not just immediately going into hyperdrive mode where you're just like, all right, I'm going to do a critical intervention in a situation that I'm not, you know, overly familiar with limited resources. So having your resources is really smart there. And I can't remember the name of the study. I was trying to look it up. Bradley sent this to us maybe a few weeks ago. This was a major airway study that was conducted pre-hospital setting where it was a review of literature and intubations. And basically and it was controversial, and I don't know if we brought it up yet. And most of the conclusions is that EMS would do better to just maintain airways using basic techniques or even supraglottic airway devices. Now, there's a lot that you can extrapolate from that research. There's a lot of missing data. There's a lot of gaps, and there's a lot of training issues that were not addressed when it came to that. But they're basically saying, you know, in those studies, it would be better for EMS in some instances, most instances, to maintain oxygenation using simple methods, even supraglottic airway devices, which is a huge slap in the face to the gold patched medic. So to your point about after you got the CPAP, really assess your patient and make sure that it's appropriate, because otherwise you're getting ready to go down some pretty treacherous territory into what I like to call a halo event, high acuity, low occurrence event. And that can breed danger in and of itself.
Sure, exactly. And just because you can intubate your patient doesn't mean you should, right? So, you know, let's jump back to ketamine for a second. You know, ketamine in adults, that's a great question. And some people are going to be like, oh my God, I'm going to give ketamine in an adult? Absolutely, you could give ketamine in an adult. So often we think, you know, especially if you dive deeper into the emergency medicine world, ketamine is a phenomenal procedural sedation medication for children, but we can use it in adults and it works great. All right, what's the dose that we should use in a sick patient? If they're a little sicker than normal, maybe they're the septic patient that we need to pre-oxygenate a little bit. Same dose. Low dose is fine. Are there any other meds we can give? Sure, we can jump over to benzos. We can jump over to midazolam or lorazepam or diazepam, depending on what you happen to carry. But I'd use caution in that because of the respiratory depression that it can cause. And the cool thing about ketamine, and I'm not advocating for you to do this, but the cool thing with ketamine is that an overdose in it is 100% safe. If you give somebody too much ketamine, they are not going to die. Their respiratory drive is not going to go away. You're not going to bottom out their blood pressure. They're not going to die. An overdose with ketamine is 100% safe. It's okay. All right. It is an underdose, on the other hand. If you're underdosing these patients, it's quickly recognized because they're not sedated enough. All right. And you know, the other thing that I get people that question this a little bit is they're like, oh my God, what if the patient vomits? That's absolutely okay, because the cool thing with ketamine is the patient's ability to maintain their airway stays intact.
Yeah, I think that's a good point to bring up. Yeah, you can have all these nice alternatives, pharmacological, but I don't know about you, but like my pharmacology background in paramedic school was very slim. You know, we hit different medications. I knew just as much as the note card would have me learn. I would take the test on it, pass it, and then I was, almost etch a sketch that entire experience. And then the rest of it was just kind of experience on the streets, where sometimes you give like intranasal, Versed to somebody and it knocks them right out. You give it to somebody else and it doesn't touch them. So you have that variable. What we really want to point out is outcomes. Like you said, I mean, you can't overdose someone on ketamine. Not to the point that we would be that it would be an acute crisis that we have to manage. So to me, that would lead to better outcomes for these patients, even in the presence of you not being able to establish or secure an airway. So if the math was off a little bit, hey, you know what? You're not going to do any further harm.
Exactly. So what patients should we really look at with this? It's tough. The patients that we can't do this on are apneic patients, right? So occasionally, even though the patient's apneic, we need to RSI them because they have a clenched jaw, they're experiencing some trismus or whatever. And they're going to require paralytics. Obviously, they're apneic, so we don't need to worry about sedation for them. But they're not going to be a patient that you choose to use ketamine on and do some DSI. All right. Any patient that is not apneic and is giving you some trouble, those are patients that you may consider on. Those folks that you like we talked about, that you can't necessarily pre-oxygenate well. Right. The patients that are fighting you for whatever reason. You want to put that non-rebreather mask on and they're losing their mind, let alone a CPAP mask. You got to bring their stress level down, right? Bring their stress level down, bring their fight or flight response down a little bit, and you're going to have pretty good outcomes. You almost just want to, kind of consider the fact that you just want to down-regulate these folks just a little bit, and you're going to have usually pretty good outcomes with them.
Yeah, you're just saying, like, this is being more used as an anxiolytic. You're just trying to get their anxiety down.
Right. Absolutely. It could be done with any patient that needs a procedure to make their airway safer. Any patient, realistically. It's for the most part in the pre-hospital environment a pretty novel concept. But it can be done really well within the comfort zone of a paramedic who's well trained to do rapid sequence airway, rapid sequence induction, and this is just an extra tool in your toolbox when it comes time to do airway management. When you take your approach to this procedure and your approach to these patients, this is a single procedure. All right. RSI, multiple different procedures, all the P's of RSI: preparation, pre-oxygenation, pre-medication, all that other stuff. DSI is a single procedure. That's it. Right? You draw up all your meds. Right? But if you're smart, you draw up all your meds for DSI and then you draw up all your meds for RSI as well. Because if it can go wrong, it will. And if we prepare for it, we're going to have a significantly better outcome in our patients. Not that I'm saying this is going to go wrong, but prep for the next step.
Yeah. No, I like this. In fact, can we do one like that where just like kind of, I like doing like mental maps or mind maps, whatever you want to call them. Kind of out loud, like you got a patient, you decided you're going to DSI them. Can you just walk me through your process and your decisions on what you're doing and why?
Yeah, so you make the determination that you're going to DSI them, you're going to give them 1 milligram per 1 kilogram of ketamine, and you get their anxiety down, and you're able to pre-oxygenate them. And for whatever reason, you determine after you pre-oxygenate them, which is successful, that, man, I don't like their ventilatory rate, I don't like the way they're maintaining their airway, or you don't like their clinical course, their expected clinical course, then you can move down the road to intubate them. Okay, so you knock them down with ketamine. If you want to fully induce them, you just give them some more ketamine. And then you go with your paralytic, and magically you're in the realm of RSI now. Right? Because I mean, you can induce patients with ketamine for RSI all the time. I used to be an etomidate and succinylcholine guy for RSIs forever. I'm now a ketamine and rocuronium guy. So you could just further induce.
Why is that? What made the switch?
Ketamine, as we talked about, doesn't really mess with your respiratory drive much. So if I get to the point where it's time to push the paralytic, and something's telling me not to push the paralytic, it's okay. They've still got their own respiratory drive. It doesn't have cardiovascular collapse issues with ketamine. And then rock, it lasts just a little bit longer, and and it's a non-depolarizing neuromuscular blocker versus a depolarizing neuromuscular blocker. So you don't have to worry about the fasciculations with rocuronium. And instead of sucks, which lasts 7 to 10 minutes, rocks like 15 to 20. That comes with experience and comfort level as well in your ability to maintain and gain control of that patient's airway. If you're doing RSI for the first couple of times, sucks is probably the way to go because it only lasts 7 minutes. And with good training, you shouldn't have to worry about that. But as you get more comfortable, maybe rocuronium is going to end up being your friend because it does keep the patient paralyzed a little bit longer. But there's also some comfort that comes with knowing that you can manage that patient's airway. You're not like, oh my God, if I miss, they're going to be paralyzed and not able to breathe for up to 20 minutes. So it's a comfort level and a skill level thing with doing that.
Well, speaking of which, what do you think is good training for DSI and RSI?
Intubations. If you have the opportunity at all in your practice, at whatever level you happen to be, if you have the opportunity to do procedural cadaver labs or to get into the OR, and it doesn't even matter if the anesthesiologist in the OR lets you do the intubation or not, visualizing those airways is huge. Spending some time with your airway mannequin is important. Becoming familiar with your equipment. Are you doing direct laryngoscopy? Are you doing video laryngoscopy? Become a master of your equipment. That's huge.
Yeah, I like the idea of mastering your equipment. I call it Murphy repellent.
Yes.
If you have it all out. So when it comes to that, because I'm wondering, do you what do you do at your facility or your agency when it comes to training? Like, do y'all have upkeep training that you have to do like maybe every 3 or 6 months for it?
Yeah. Your amount of field intubations that you have that are successful. It's been a little difficult with COVID and all the stuff with that to get into the procedural cadaver labs that we like to have our folks go through. But when we have the opportunities to get into the cadaver labs and look at some, this is going to sound horrible, but some freshly dead airways, that's important. And we have the opportunity then as well to do practice on the skill that I think that I'm pretty good at, and I hope that I never have to use, and that's surgical airway. Because if you are pushing a paralytic on a patient at all, you need to be prepared to cut that patient as well. If you're going to push a paralytic, you need to be prepared to cut. Now, I'm not saying that you ever are going to, but the reality is if you push a paralytic and you end up getting down into that crash airway where you, for whatever reason, you have a failure to oxygenate, a failure to ventilate, your next step, your only step, if you can't revert back to BLS or anything like that, is to do a surgical cricothyrotomy. I've made it, 15 years as a medic without having to do a surgical cricothyrotomy. I want to make it my next 15 years without having to do one. But, making sure that you are trained and proficient from simply starting IVs and pushing medications all the way up to that surgical airway is important, because that's all part of that RSI. Soup to nuts, start to finish. That's all part of it.
So,
and then the knowing, as Eric mentioned earlier, though, knowing your secondary airway is important as well. Do you know, and are you well versed in your supraglottic airways? Be it a King LT, be it a iGel, an LMA. How well familiar are you with those?
Yeah, and that's what I was going to ask about. Like, because I don't want people to walk away from this thinking, oh crap, if I do a crash airway, can't get them intubated, the next thing is a cut. When I'm like, no, you can revert back to BLS, good BLS skills. So have you seen any studies or experiential, anything from your place, from your experience from supraglottic devices that you favor, like Kings versus iGels versus LMAs?
We have Kings in my service right now. We're probably going to switch over to iGels at some point. And we actually stopped calling RSI. We started calling it RSA, rapid sequence airway, instead of rapid sequence intubation. There's an airway is an airway is an airway is an airway, right? It doesn't matter.
I like that.
It
That's
doesn't
nice.
matter if it's an intubation. It doesn't matter if it's a supraglottic airway. What matters is that you took over the patient's airway and has a positive outcome with it. It doesn't matter who made the device or what kind of device it is. An airway is an airway. And I felt so defeated the first time I RSA'd a patient, and I put in a king. I felt super defeated. And then I rolled into the trauma center with this patient, and I watched two trauma docs fail to visualize the patient's vocal cords with a glide scope. And they had to get an anesthesiologist from the OR in to get this patient's airway. And then I didn't feel so defeated anymore. You know,
No,
because
yeah.
if it was hard for me with a McGrath to visualize the patient's vocal cords, and two, trauma EM docs couldn't see the patient's vocal cords with a glide scope, I didn't feel that bad. I thought I'd missed something. But once I realized that folks that are a lot smarter than me with a lot more experience in this regard than I have, when they couldn't see it, I didn't feel that bad. So the take-home message of folks listening to this: if you go to a supraglottic airway, that is not a failure. If you get an airway and you're able to oxygenate and ventilate that patient, that's not a failure at all. That's a success. And don't be afraid of it. Don't be afraid of saying, oh my God, this patient's airway looks like crap. I'm gonna go with a supraglottic. Do it. It's fine.
Yeah, that's I really like that rapid sequence airway. Just that change in terminology, I think for me, like reduces the stress load that initial the RSI brings to it. Because I think Bradley posted something about do it for Drew on our Facebook thing.
Yes.
I think a few days ago. Yeah. So like, don't just freeze. Throw what you can down this person so that you can get an airway. Because if you're just like if you're making multiple attempts to intubate and all that stuff and it's just not happening, at some point you have got to take your ego out and realize it is a paramedic patch, not an intubation patch. We're just here to care for people.
Yep. Yeah, absolutely. That's huge. And the do it for Drew campaign. If you're not familiar with that, do a quick Google search on it. If you're hooked up with Bradley on social media or even on the group here with the EMS Handoff, take a look at it. I've listened to Bradley give the talk before. It is phenomenal stuff. And I take making sure my airway is in place so seriously that whenever I intubate a patient, I'm weird. I do some weird stuff with airway management. I preload a bougie onto my ET tube every single time. I prep for a bad airway every single time, even when it's on the 97-year-old cardiac arrest that weighs 110 pounds, that I know is going to be an easy cakewalk airway. I prep and I act like it's a bad airway every single time. That way, when it is a bad airway, it's not so bad anymore. So I've got the bougie hanging out of the end of the endotracheal tube. And on the top of my endotracheal tube, already hooked up to the monitor, is my end-tidal CO2 detector. My waveform capnography device is already hooked up to my tube. And when you're doing an RSA, it doesn't really work out that well. But when I'm working a code and I don't interrupt chest compressions, the minute that endotracheal tube passes the glottic opening and there's chest compressions going on, there's air going in and out of that trachea with those chest compressions, I keep the monitor at the feet. I set up my codes real weird in comparison to some other medics. Monitors down at the feet. That way, when I'm up at the airway, I could see everything. That ET tube goes through that glottic opening and there's chest compressions. I see an instant waveform on that monitor before I even inflate the cuff on the endotracheal tube. Now, granted, it's not a pretty waveform, but it's a waveform. I know I'm in. And I have that monitor facing me while I'm up at the head all the time, because I can watch in real time and ensure that my tube's in the right hole and it's staying there. And if I can allude anything to the Do It for Drew campaign, do that. And you could do the same thing with a supraglottic airway. You could preload your waveform capnography device onto the supraglottic airway before you even put it in the patient. It's already there. Back to that preparation, back to that being ready for success. I look at coaching my son's lacrosse and soccer teams the same way I look at taking care of a patient. Prep for success. Get the steps, get the training, get the skills that you need, using the same way every single time, and you're going to have a positive outcome. You know, that ball's going to go into that net, or that tube's going to go into that hole, and you're going to get positive outcomes with your patients. It's the same thing. You know, taking the steps up front is going to save you a lot of hassle down the line. The last thing I ever want to do is roll into an ED and be like, I think the tube's in the trachea. I'm not sure. Their stomach's 5 times the size it was when I started, but I think it's in the right hole. No. You know, all the medics that I teach, I tell them when they start class, right? I'm not going to let you loose until I am comfortable that you're going to be able to take care of me and my family. Right? I the same way. I'm not going to take care of somebody in a way that I wouldn't want my family to be taken care of. And airway is huge.
Yeah, and that waveform capnography you talked about, that it's got to be, it's standard. I mean, it is standard airway, should be standard airway. We know it has good outcomes associated with using it for identifying airway. So I'm glad you put that in there. You know, 35 to 45 is what you're wanting. I will tell you though, just from my experience, King Airways, I have not had much luck with end tidal on some of those things during CPR anyways. During live
Right.
patients are fine, but yeah.
Yeah. You know, and it is what it is with them. But at the end of the day, if you're getting some kind of waveform back on that, you know you're not. You know you haven't buried the thing in the esophagus. You know you're getting some kind of gas exchange, and that's important. So we kind of dove down the intubation and end tidal CO2 rabbit hole for a second. Let's bring this back to DSI. So we dropped some ketamine on this patient, 1 milligram per kilogram. Let's say we got a 100 kilogram patient. Perfect. We give them 100 milligrams of etomidate. All right. So we give them etomidate. Goodness, not etomidate. Geez, ketamine. We give them ketamine. Lots of ketamine. No etomidate. So we give them some ketamine. We test a non-rebreather. We see how that goes. Or if you know that your patient is sedated, well, jump right to CPAP. It's fine. I know in most regions and in most states, it's totally 110% against protocol to give CPAP to an unresponsive patient. Well, we made them unresponsive. We're doing DSI. This is also something that I could almost guarantee you're going to be required to do medical control for before you do this. You know, my region, you have to call for RSA orders. When I call, I say, Doc, this is what I got. I want to try DSI, and if it doesn't work, I want to go to RSI. Okay. If you know, and my agency's chief medical director is Scottish, and it's funny. He's like, oh yeah, just give a little bit more ketamine and paralyze them. If the DSI doesn't work, it'll be okay. I can't believe I just said that. It's going to be recorded and put out to the masses in that accent, but I did. So it's absolutely fine, and odds are you're going to end up getting this patient up to 100% SpO2, and that's fine, because I guarantee we started somewhere below 90, and that's why we're doing this. So getting that patient up there is good. You could back off, excuse me, and get that. You know, you could titrate things a little bit afterwards and get them a little bit south of 100%, because we never want to keep our patients at 100% SpO2 for a super long period of time. But we can back that off and titrate all that. So you know, you get some questions with ketamine about patients' cardiovascular systems, and should I use ketamine on everybody? Some folks say that you shouldn't use ketamine on somebody who's hypertensive and tachycardic. I fight back with why. What's it going to do to them? It's not going to make them more hypertensive. It's not going to them more tachycardic. And they're probably hypertensive and probably tachycardic because they're in fight or flight thing right now. Their sympathetic nervous system is taken over, and that could be due to their hypoxia. And if we fix that after some ketamine and some positive pressure ventilation, I guarantee the hypertensive issues and the tachycardic issues are going to come right back down. You know, some of these patients could become complex. So in an ideal world, say we're doing this in an ED, we have some different options, but we're not in an ED. You can use dexmedetomidine. I can never say this right. Dexmedetomidine. It's kind of like clonidine. It's an alpha 2 agonist. It has some dissociative properties as well. It works well with conscious CPAP use, but the problem is it's not quick enough and it's not strong enough for what we really want it to be in the field. So ketamine's really our friend. I'm showing my age here. Another thing that you could use is droperidol. That hasn't been out in a while. You could have the same effect with it. You could use it well with fentanyl. The problem is it's a black box drug because of its ability to really elongate your patient's QT interval, and that's bad.
Yeah, we want to try to keep their QTs nice and tight. We don't want to laffy taffy them.
No,
that'd be a bad idea.
Right, and the point of just talking about some of these other agents is there are other options out there. If you're working in an ED with a pharmacist next to you and all that, but at the end of the day, our drug pre-hospitally, that wasn't a paramedic class drug card when I started. It wasn't even thought about using it in the field when I went through paramedic school. It's ketamine, and I am so glad that we have it. There's so many situations that I've used ketamine in that if we didn't have it, I'm not sure how well my patient's outcome would have ultimately been. So ketamine is huge. And the interesting thing to think about here too, in comparing RSA versus DSI, is known and unknown. I'm a really big fan of control, especially with my patients and my scenes. I like to be in control and to know what's going to happen. With DSI, I know that. And that's why I'm a big fan of it. With RSA, RSA you've got a lot of unknowns in there. So that's important. And the last thing I want to talk about while we get ready to wrap up here is when you complete DSI, you then have one more question that you have to answer. And that one more question that you need to answer is a simple one, and that is, does my patient need to be intubated? And the answer to that is a statement that's not 100% definitive, and the answer to that is some patients may improve without intubation. Some patients will do fine. Other patients may not do fine. You may be able to pre-oxygenate them, like I mentioned when we did that little mind mapping thing with Eric back here a few minutes ago. Some patients just need to continue down the RSA road after that. So, continue your ketamine for your full induction. And then continue on. We could sit here and talk about the pharmacokinetics of ketamine for a long time, but with this just being a podcast, if you're going to use ketamine and you're not familiar with it, studying the pharmacokinetics and pharmacodynamics of ketamine is your responsibility. If it's a medication that you're going to use and you're not familiar with it, do the research, get the education. This podcast, we could do a whole hour-long talk on ketamine. And, I think I probably just signed myself up for another podcast topic.
Yeah, probably actually. Yes. Oh, yes. Oh, that'd be brilliant. We could have you on it. We'll have you on again. This is like, aren't you a fourth time offender?
That will be the fourth time. Yes. Yeah.
It will be that. Okay.
Number 3. Yeah.
All right. Yes. Number 3.
But just, starting out there and using it as a tool to, I don't want to say avoid intubation, but that's really what we're doing. If we don't have to intubate a patient, I think your outcome is going to be better. So many patients that we end up intubating that end up on a ventilator, they have some, they may have a hard time coming off it. Some don't if they're young and healthy, but man, in the world of COVID right now, patients get intubated and they get put on a ventilator. That's not a good outcome for them generally.
No, and that's
If we can manage airways, even in our non-COVID patients, in our even in our trauma folks, if we can manage airways without putting them on a tube and get them on a ventilator, they're going to be better. There's so many complications that come down from prolonged intubation that if we could avoid it, it's going to be better for our patients.
Yeah, and and this is a timely podcast considering that ICU beds are filling up. So even if you do intubate or you have an advanced airway in somebody, where are you going to take them, and are they going to have room for them, and what are their outcomes are going to be like? So this is
the ED is not a place to board an intubated patient, that's for sure, but it happens all over the country right now.
Yeah, absolutely. Well, Man, this has been a great topic. This is good because like I've never heard of DSI. Like I said, I was calling it everything under the sun with Bradley. I was like, wait, what are we doing now? Is it like death scene instigator or something like that? I had no idea. He's like, no, it's DSI. It's delayed sequence. Okay. So not death scene. No, not that at all.
Oh, it's just Jason. It's just Jason guy again. We're starting with D. It must have something to do with documentation.
Actually, yeah. And that's a good plug. We actually have you on a previous podcast where you're talking about documentation, which actually it's not a boring podcast. In fact, I should probably retitle it as Not a Boring Documentation Podcast or Not Another Boring Documentation Podcast, because there's a lot of them out there and I know they're all kind of, but that one wasn't boring at all. I didn't think, but well, awesome. This has been I think it's been a good episode. What do you think, Bradley? Has this been a good episode for you?
Oh, absolutely. I mean, we could have gone into down a rabbit hole of oxygen theory and everything else. The one thing I will say is, he mentioned earlier that it's a paramedic patch, not an intubation patch. Don't judge your ego by the size of your laryngoscope blade. Make sure that you can manage an airway.
I like that. That's a good parting blow, especially to. I think that I might be wrong. That might be applicable more to like the new medics who haven't experienced the humbling nature of our field. I liken what we do to, and I know we're not Navy SEALs and Army Rangers. I got all that, but I liken what we do to what they do. They are put in stressful situations, austere conditions, terrible environments with nearly unmanageable situations, and sometimes we're in very similar situations like that, and we're just doing the best that we can to get the patient there. And that doesn't mean that we got to throw the entire box of skill sets that we have honed in over the past year or so of paramedic school in order to get that done. Sometimes it's getting the patient in and they are breathing, and that is good. So
right, and it just goes back to that previous point that I made. Just like special forces folks, Rangers, SEALs, all that. They are only successful because of their training and their preparation, and they have a plan and they execute it. And we do the same thing.
Absolutely. I heard this once. I love it. It's like, you will not rise to the occasion. You will fall to your level of training.
Yes.
And that is absolutely true. So, well, awesome. And Jason's already signed up for at least another couple podcasts from what it sounds like. Bradley heard it. I think all the listeners at this point has heard it too. So,
yeah, and then Bradley's gonna in person knock me down on this in October 1st or something like that, right?
Oh, good.
I gotta figure out when I'm gonna get there.
Ooh, nice.
Friday for dinner, man. Absolutely.
Yes.
Awesome, guys. Well, thank you again for another awesome podcast. Again, this has been EMS Handoff Podcast. Make sure to visit our vendors, Pursue Outfitters, to check out our line of clothing. We have our website, emshandoff.com. The most vibrant community, though, is really on Facebook and YouTube. That's where we get a lot more of the interaction. So make sure sign up for our Facebook group. Usually, if you request to be a part of it, we'll get you within a matter of hours. Depends on who's tag teaming on it at the time. So for Jason Haag, Bradley Dean, the absent David Blevins, and myself, we want to wish y'all actually a really good weekend. To make sure that you stay safe and remember the value of your EMS handoff.